Welcome to Heart and Stroke Presents Healthcare Insights During COVID-19, a podcast and YouTube series with leading healthcare experts in cardiac and stroke care. This series brings you the latest updates from the COVID-19 front lines. Leading experts in stroke, cardiac, and vascular cognitive impairment share their insights into how systems of care are adapting to the pandemic and how these systems may change in the future. In this video, Dr. Gord Gubitz, a neurologist at the Halifax Infirmary, joins us to share his expertise and answer questions about the switch to virtual care during the COVID-19 pandemic, including virtual care delivery, challenges, and insights for future success.
So Dr. Gubitz, thank you for joining us today. We're really looking forward to hearing from you. And first of all, thank you to yourself and to all the healthcare workers that have been working so hard on the front lines under just unreal stresses and unusual circumstances that has caused you to change your whole way of delivering patient care. So thank you to all the frontline staff from all of us. It has meant so much to the people with our conditions. Today we want to focus a little bit on a major shift that happened, which was the switch to virtual care. In stroke care, we've always had that for the acute care, but never for rehab and prevention. And in fact, many of our teams have been fighting very hard for that and not making a lot of leeway over the past several years. So if it's okay, I would like to talk to you about this.
Absolutely.
Great. So let's start with some questions. And also we invite our audience, if you have questions for Dr. Gubitz, please post them in the question part of the GoToWebinar and we will get them answered. So tell us a little bit about what was it like to suddenly have to switch your care to virtual for all of your prevention clinics?
Well, Patty, I guess the first thing is it wasn't sudden. It was a gradual process because at the beginning, everybody was just trying to figure out what the heck was going on, generally speaking. And so it might be different across other provinces, but in Nova Scotia, things fell apart gradually. And one day this shut up and the next day this was closed, et cetera, et cetera. So we found ourselves having to deal in our outpatient prevention clinics with booked lists of patients who were this started in February, March, so for the months of April and May as an example, and all of those clinics were just suddenly canceled. And so there was a good week there where nothing really happened because we didn't know how long all of this was going to happen for. And then it became a massive project of re-triaging patients and trying to get a sense of, well, how are we going to do this? So for the early part, for the first early couple of weeks, a lot of it was just quick telephone calls, checking in with patients and saying, you were asked to see me for this, am I correct? So almost doing a bit of a history on the telephone and getting a sense, do I need to see you in person? Should you come to the emergency department? If your symptoms were in a timely sort of way. So those rapid transient ischemic attacks. As you've reported on, and it's the same with heart disease, a lot of patients simply disappeared. And so there was a significantly fewer number of people coming to the emergency departments. So we weren't feeling the pressure from that side, but we had all of these outpatient things that we had to take care of. So that was the beginning. After the telephone happened for about a week or so, and as we started to get a sense that we were using Zoom and other platforms like GoToMeeting and that sort of stuff to see each other as professionals and to deal with the meetings, then gradually there was this, well, maybe we should be doing this with patients as well, as opposed to just telephoning. And that brought us into the whole idea of, we don't actually have technology to do that. So our institution has to purchase a license and they have to go through their legal department to make sure that people don't get Zoom bombed with the profane images that were coming across other people's servers, etc. So that took a little while. And then eventually we got to the point where it became possible to see patients. And then of course, forgetting about the back end and thinking that the patients don't have the technology either. And have to learn how to download things and how to dial in and all those things that we've all experienced, everybody on this call has experienced, trying to get a line in and recognizing that you don't have enough bandwidth or that your microphone's turned off or that you don't have a microphone or stuff like that. So it wasn't a sudden shift, it was this evolution. And I think to the credit of everybody who's involved in these processes and simply because it was happening to everybody at the same time, we got forced into it. In the same way that people got forced into learning how to bake bread and make cookies, which seems like everybody else has been doing that.
That's if you can find the flour and the yeast.
Or the yeast, yes, yeast.
Okay, that's very helpful. For some people, though, there's certain things you can't do virtually.
Mm-hmm.
You can't measure their arm strength. You can't, get a good sense of their swallowing. What do you do in situations like that where do you just not cover those things, or are there people still having to come in?
Yeah, so I think that's the triage part. So in reviewing for the secondary prevention clinic that I do, a lot of people I had seen before. And so those people, maybe a telephone call, how are you doing? Do I need to renew any of your prescriptions? Who's measuring your blood pressure? Our biggest question is, if you're not coming anywhere and you don't have a kit at home, how are you getting your blood pressure measured? And I don't know if it's like it where you are, but our pharmacies got rid of the blood pressure machines because they were high touch surfaces, right? So trying to figure that out is important. It is possible for a neurologist using a microphone and a camera to do some basic neurological assessments. So I can get people to do arm strength and arm drift. I get them to stand up and walk around the room. I get them to stand on one leg if they're able to. And I can do cranial nerve testing with the camera. So I was able to diagnose one person with a visual field, and you can do finger camera finger to look for that sort of stuff. There were a number of people, however, where it became apparent, and within the general realm of neurology, if somebody's coming in with a mild progressive weakness or something where you actually have to sit down and check reflexes, you can't do that on the phone or on a Zoom call. And so those people are being, if we're able to open up our clinics, we were bringing in one person a week, scrubbing everything down, trying to get stuff done like that. And then for the teaching around signs and symptoms of stroke and getting, calling 911 and getting to the emergency department early if you think you're having symptoms, and not being worried that you're going to catch COVID and die in the emergency department, because people were very worried about that too.
For sure. And we've been working with our colleagues to really promote coming to hospital with
Absolutely.
our CCS colleagues, and
Yep.
our comms department's done a great job on that.
Yep.
In terms of your patients, and you're saying they have challenges with not having technology or knowing how to use it, a lot of elderly patients, how have they generally responded to virtual care?
I think once they've gotten over the concept, it's pretty good. I mean, people were blown away that we were actually phoning them at the beginning. And initially, I didn't book appointments. I just assumed everybody would be home. They weren't. I don't know where they were, but they weren't at home. So our admin staff, and it may be similar in other places too, our admin staff were sent home. So they weren't in the hospital. So I was getting text messages from my admin staff trying to get into my calendar so we can book a patient. They phoned the patient to say, can you expect a call at 2 o'clock on Thursday afternoon? And then we'd have a conversation. So initially that was fine. Then it was the tech staff trying to instruct patients how to download Zoom or whatever, because Zoom's the platform that we're using here. How to position the camera and all those things that people need to know. For a lot of people who've survived a stroke or folk with other health problems, it can be a challenge to deal with and access that level of technology. So I've had a number of circumstances where they've called a family member in, and so the number of people with nephews who know how to use a laptop who end up showing up, and then it's kind of awkward because once the connection's made, say, "What? Could you go to the kitchen now? I need to have a conversation with your grandmother about her stroke symptoms." So maintaining the physical distance, but also the privacy around the healthcare encounter is important.
For sure, that's been a big issue. And then going forward, if we think about this, is this going to become commonplace? You saw in our poll that a lot of our staff would like to have combined care. So, it took us so long to get to this point, and all of a sudden it's here. We don't want to lose this ability. What do you think are going to be the key ingredients that we need to think about going forward in order to fully integrate virtual care as part of our caregiving?
That's a tremendously important question, because there is the possibility that it could all be taken away. We're making assumptions as healthcare providers that we've got this process in place now. We've got the technology. There are billing codes. There used not to be billing codes. So you were doing this and saying, I don't know how the system would recompense people for their work, right? So for people who are billing fee for service, that's a huge problem. I'm on an AFP plan, so I get paid just to be here. I love that. So the idea then is, actually here in Nova Scotia, there's a thing in the news yesterday that the Minister of Health hasn't decided whether or not this is something that ought to go forward. I think from a patient perspective, in talking with them, if you didn't have to drive to the hospital, if you didn't have to pay for parking, if you didn't have to take time off work to take your mother to the hospital and take time off work and get parking, and didn't have to wait in a waiting room, if you didn't have to wait for the physician to be a little bit late sometimes, and then drive all the way back home, you're losing hours out of your day. And so if this could be done in a 45-minute telephone conversation, why not do it that way? And so certainly a large number of people will still need to be seen in person, obviously. And I think as we go forward, we learn about that more. We develop better triage tools to say, you need to come see me, you need to go to the emergency department, I can phone, I'll do a virtual visit by. I think that the public probably needs to start asking the administrators in our governments these questions, right? So it would be very interesting for your Minister of Health to know the results of your 70-person poll of educated healthcare people, to say, going forward, this is something you might want to know. We need to create a system where we can have both.
Great, thank you. And our final question to you as we wrap up is, you started to talk about what heart and stroke can do. Where do you see the role of heart and stroke in pushing virtual healthcare going forward?
So I think that by taking a page from your own book, it's almost like we'd not talked about this before, but here are the virtual healthcare telestroke implementation toolkits 2020. All right, so this is, for those of you who haven't read this yet, this is like bedside must read. Just put out in terms of helping clinicians and other healthcare providers to access patients. There's a little piece on the bottom of page 5, and I don't know if you can read this at the very bottom, I'm just holding it up. It's basically tips for effective consultation for individuals participating in virtual healthcare, so for patients and families, and it gives some general things. After that, there are a couple of tables which have sort of tick boxes of what you should consider. I think if we develop for the patients that we serve an infographic, a 1 or 2 page infographic. Am I using the right words, Patty?
You are. I didn't even plant this one.
You didn't even plant this one. I thought about this all by myself. So thinking about an infographic that could then be distributed so that when patients are discharged from hospital, or if they're seen in a secondary prevention clinic, we might be arranging your follow-up by telephone or by virtual technology. Here's what you need to know, and here are some resources that you can go to, so that we don't have to do this all, make it a stressful thing. So I think the people are afraid of technology, especially our population, so making it easy for them. So infographic involving the work that you've already done.
Thanks for watching this episode of Healthcare Insights during COVID-19. You can find more virtual care resources for both healthcare providers and patients and caregivers at strokebestpractices.ca. To learn more about how systems of care have adapted to meet the needs of people and families, listen to our new podcast series that features leading experts from across Canada. If you are looking to connect with others living with heart disease and stroke, join our online peer support communities. Here you can ask questions, receive support, and get practical advice. Take good care.